This is an overview of the lower limb, in which I'm going to highlight the structural components of the lower limb, including bones, joints, muscles, nerves, and vessels, and how these components are organized in order to better serve the function of the lower limb. Innervation of the lower limb is by lumbar and sacral spinal nerves. Somatic, motor, and general sensory innervation of the lower limb is by peripheral nerves emanating from the lumbar and sacral plexuses on posterior abdominal and pelvic walls. Nerves originating from the lumbar and sacral plexuses and entering the lower limb carry fibers from spinal cord segments from levels L1 to S3. These nerves, the branches of the lumbar and sacral plexuses, are tested clinically in the lower limb to diagnose injuries and locate disorders affecting these spinal nerves. For example, a herniated intervertebral disc, or what is also known as slip disc. Before continuing with nerves, the concept of dermatomes and cutaneous nerves should be introduced and a bit explained. A dermatome is the skin area that is innervated by the fibers of a single spinal nerve. These spinal nerves intermingle in nerve plexuses. Thus, the branches of the plexuses contain fibers from more than one spinal nerve. So it's important to differentiate between dermatome maps and maps indicating the cutaneous distribution of peripheral nerves arising from the plexuses. As you can see here, two maps. One of them is for the dermatomes and the other is for the cutaneous nerves arising from the plexuses. It's important to consider that dermatomes generally overlap and there are no rigid boundaries between the dermatome regions. Regions that can be tested for sensation and are reasonably autonomous, that's to say have minimal overlap, are over the inguinal ligament for L1, lateral side of the thigh for L2, lower medial side of the thigh for L3, medial side of the great toe, L4, and the little toe, S1. S1 extends to the heel, as you can see. So remember that you stand on your S1 and sit on your S3, while S2 is the strip, long strip in between. Now, regarding the motor innervation, each of the major muscle groups or compartments in the lower limb is innervated primarily by one or more of the major nerves that originate from the lumbar and sacral plexuses. The large muscles in the gluteal region are innervated by the superior and inferior gluteal nerves. Most muscles in the anterior compartment of the thigh are innervated by the femoral nerve, a branch of the lumbar plexus. Most muscles in the medial compartment are innervated mainly by the obturator nerve, another branch of the lumbar plexus. Most muscles in the posterior compartment of the thigh and the leg and in the sole of the foot are innervated by the tibial part of the sciatic nerve. The anterior and lateral compartments of the leg and muscles associated with the dorsal surface of the foot are innervated by the common fibular part of the sciatic nerve. The sciatic nerve is the largest nerve in the body and it is a branch of the sacral plexus. Finally, a point should be mentioned about superficial veins in the lower limb. So in the lower limb, as in the upper limb, the venous return is by the way of superficial and deep veins. The superficial veins lie in the superficial fascia and are not accompanied by corresponding arteries. They play a major role in temperature regulation. Since the superficial veins lie beneath the skin, they can be seen through it and look blue in color because of the reflection of light through the skin. This has nothing to do with the color of blood in the veins, since the color of blood in veins is red and not blue. However, in old days, landowners and royal families who lived an easy life without much toil or manual work, They have their hands white in color, and the blue veins can be seen easily through the skin. So it is said that they have blue blood in their vessels, indicating their high ranking in the society. On the other hand, peasants used to work all the day in the farm, so their skin is dark, rough, and veins cannot be seen through it. A superficial vein leaves each side of the dorsal venous arch, which you can notice on the dorsum of your foot. The preaxial vein is the great or long saphenous vein in the lower limb, and the cephalic vein in the upper limb. The long saphenous vein leaves the medial end of the arch, while the cephalic vein, the lateral end of the arch, but both are preaxial, if you remember the embryology. The preaxial vein runs to the root of the limb in both cases and pierces the deep fascia to open into the main vein of the limb, the femoral vein in the lower limb and the axillary vein in the upper limb. The postaxial vein is the small saphenous vein in the lower limb and the basilic vein in the upper limb. They pierce the deep fascia proximal to the root of the limb. In the lower limb, the small saphenous vein pierces the popliteal fascia and joins the popliteal vein behind the knee. In the upper limb, the basilic vein pierces the deep fascia in the middle of the arm and joins the vena comitans of the brachial artery. The word saphenous is probably the only anatomical term that has an Arabic derivation. It is derived from the word saphen, which means standing because it doesn't pulsate. A portion of the great saphenous vein can be used as a graft to bypass an arterial obstruction, such as in coronary artery bypass and grafting. The superficial and the deep veins also communicate with each other throughout their length by perforating veins, which penetrate the deep fascia from superficial to deep. These perforating veins contain valves that allow unidirectional flow of blood from the superficial to the deep veins. Now, when the muscles contract, their contraction will propel the blood in the deep veins toward the heart. Blood is prevented from passing to the superficial veins because of the presence of valves in the perforating veins. Now, if these valves become incompetent, if they fail, then the blood is pushed inversely from the deep to the superficial veins. Therefore, the superficial veins will become dilated and tortuous, and this is what we call varicose veins. We have noticed that many structures in the lower limb can be spared to replace other structures in the body. In this extreme example of a young lady from Brazil who was born with absence of the upper limb, the whole lower limb, in addition to supporting the body weight and locomotion, has successfully replaced the function of the upper limb. We can see her here washing dishes, eating, combing her hair, writing, and even taking a selfie.